Hello, everyone. Hope you're all having a good day. I'd like to welcome you to our workshop on HIV prevention and women. My name is Ella Rocker, and I'm pleased to be welcoming Dr. Mia Biondi and Dr. Melanie Murray. We're going to be discussing HIV prevention, the specifics of HIV prevention medication for women and people with female reproductive systems, as well as their work and programs in both Ontario and British Columbia. This webinar is taking place on April 18, 2023. And as you come into the room, you will notice that we are recording this session so that we can share it with people who are unable to attend today. This webinar is being organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek system change by shifting the conditions that are holding the problems in place. I'm speaking to you today from Winnipeg, Manitoba on Treaty 1 territory. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We're humbly working together on the Truth and Reconciliation Commission's calls for action and the missing and murdered Indigenous women and girls inquiries calls for justice through our research, our events, and all the other projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network or sign up to receive our newsletter, you can do so at cinetwork.ca. We have quite a few people registered today, so we're going to ask folks to keep your microphone muted, and we will be holding questions after Dr. Biondi and Dr. Murray speak, and we ask that you type your questions into the chat today. You're welcome to post those questions in the chat throughout the session. And with that, it's my pleasure to introduce our two speakers today. Dr. Mia Biondi received her PhD in Microbiology and Immunology from McGill University, with postdoctoral fellowships at Toronto General Research Institute and the National Microbiology Laboratory. During her postdoc fellowships, Mia completed her clinical training at Western University to become a registered nurse and then nurse practitioner. Clinically, she is a practicing primary health care nurse practitioner and oversees focused practice in urban street outreach and rural and remote communities, in HIV prevention, Hep B and C, and mental health across the province of Ontario, Canada. In her free time, she volunteers as a primary care nurse practitioner to support persons who are at risk of or are being trafficked. Mia is an assistant professor at York University and oversees the primary healthcare nurse practitioner program. We also have on the call today Dr. Melanie Murray. Dr. Melanie Murray is a clinical associate professor and Michael Smith Health Professional Investigator in the Department of Medicine at the University of British Columbia. She is also an infectious disease specialist who provides HIV care at BC Women's Oak Tree Clinic and a staff physician at St. Paul's Hospital, Vancouver. She earned a bachelor's degree in microbiology as well as a medical degree and a PhD at the University of Manitoba in medical microbiology. She then completed an internal medicine residency and infectious disease fellowship at the University of British Columbia. She is currently co-leading a study by, with, and for women living with HIV that is investigating healthy aging in women living with HIV. So thank you so much, Dr. Mia Biondi and Dr. Melanie Murray. I will turn it over to you now for your presentations.
Hi, everyone. Good afternoon. Thanks so much for the kind invitation to be here. In terms of the invitation from 9 Circles and the Manitoba Network, I think the work that you're doing is so important, and it's really nice to hear about it as an outsider from Ontario, though I did spend 1.5 years in Manitoba, and it sounds like Dr. Murray did as well, so that's exciting. We have that in common. Just by way of introductions, I just want to review a few key concepts, and I think my goal here today is to review these concepts in the context of actually how we might provide some counseling or recommendations towards patients or clients, in whatever term you prefer to use there. And so really just to think about, first of all, the types of exposure risks and the risk of HIV acquisition. And this is an estimate per act. So I'll just go through them very briefly, that anal receptive intercourse would be the quote unquote highest risk act, and probably equal to, if not a tiny bit more risky than needle and syringe sharing. I think overall, it's really important to remember that at the level of a Canadian population, HIV prevalence is extremely low. That obviously varies greatly by population, and I don't actually think in Canada we have great estimates by population, at least that are representative and holistic. And so I've decided not to show that here today, but just to keep in mind that the rates could be higher or lower depending on the population. I mean, for sure, in types of counseling around who should maybe seek out HIV prevention in terms of medication-based approaches, just a reminder of the ways that HIV can be transmitted and the ways in which it cannot. There is some pretty good provincial data around rates of HIV, but certainly we know that at least in Ontario, the rates of HIV are increasing among women. Just again, by way of review, because it really does come to importance when we talk about testing, and I will go through that as well in terms of HIV prevention medication and approaches to testing. But as you probably recall, the viral load is extremely high in the first couple of weeks of infection. If infection is established, goes down and sort of levels out over the next months to years. And that people very rarely present with acute symptoms, but if they were to present with acute symptoms, based on both a CDC guidance document as well as a publication from 2008, this might be some of the things they would present with. So fever, myalgia, rash, headache, pharyngitis, and so on and so forth. And just to mention that this table is actually differs depending on the types of routes of transmission. So it could differ based on sexual transmission, it could differ based on male-female, and it could differ if folks had acquired HIV through injection drug use. Another really important part of our counseling, we really discuss our care as holistic, and I think as was mentioned in my introduction, I really can't do HIV prevention care without doing a good amount of mental health care as well. So, we usually say that HIV prevention and PrEP or PEP is a part of a toolbox, right? So when we see folks, whether it's in counseling or they've decided that they definitely want to choose this route, we certainly offer it as a part of an approach. What's in the toolbox would include frequent testing, perhaps, maybe some sort of barrier protection, maybe some kind of medication-based detection. But then also we try to highlight a few really well-known concepts such as U equals U, which I'll discuss in a second in some of the data, as well as other approaches that could lead to decreasing HIV risk, such as treating STIs, things like that. Now, I'm a virologist by training, so I have to show some sort of slide of a virus. And really it's to highlight the targets for these medications. So these medications that I'm going to be discussing, which includes PrEP and PEP, our first line options usually target either the reverse transcriptase, which obviously is important in terms of decreasing viral replication, or integration into the host genome, which is applicable only to the PEP modality. And it's actually really important to at least have some understanding of this, because it helps us to educate our patients or clients on how it actually works, right? Why doesn't HIV establish in the context of taking PrEP or PEP? So broad strokes here, I'm sure this is a review for most folks on the call, but PrEP stands for pre-exposure prophylaxis, just a bit of historical data, approved in the US in 2014, approved by Health Canada in 2016. Prior to it being approved, a few studies were done in Canada looking at provider knowledge level, which was low, maybe not surprisingly. And I think over time, provider level knowledge has gone up, but it's certainly not at the level among generalist providers that we'd like it to be. 2 combination therapies, brand name being Truvada, and in Canada that went generic in 2017. This consists of tenofovir and emtricitabine, or the brand name Descovy, which at this point there are no generic options. Descovy is only slightly different, where there is a modification to the drug tenofovir, and the second medication is the same. So bottom line, 2 drugs, 1 pill. And we'll go through sort of the differences between those 2 things. Daily prep is how we usually term it. So daily prep is taken 1 pill once a day. And then the other format, which is becoming more and more common, and there's certainly more and more awareness around it around the world about this, is what's called on-demand, or some literature and folks call it event-driven prep use. So event-driven prep use, the counseling is really, really, really important. It's 2 pills, 2 to 24 hours prior to the potential exposure. And what you'll see here as you're counseling patients and following up with them is that a lot of people might take these 2 pills. They don't end up having the exposure, and so they don't need to continue on. Right? Does that make sense? However, if they had an exposure, they would then take another pill and then another pill every 24 hours after they've had sex. So I think sometimes in counseling where it gets confusing is, what if they have sex again in that same time frame? And so just making sure that, as is shown here in this diagram, they're taking a pill 24 hours after the last time they had sex. This was some of the really early data around on-demand or event-driven prep. It's called the Hypergay study, sort of that sentinel study that came out very, very early on. And at the time that our clinic started in 2017, we were certainly discussing this data with patients or clients, but it wasn't really until some of the larger trials came out that I think we had a lot more confidence in being able to recommend this modality. This is one of my favorite images. Prep works. We can never say with certainty that people are going to be having HIV prevention 100% of the time, but it's extremely effective. And then 2 other concepts that I just want to introduce are the idea of undetectable equals untransmittable, and when folks are in a discordant relationship, that they may still want to be on HIV prevention. So I think this scenario here is someone might have an HIV positive partner, and they might be undetectable, and they still want to take PrEP. They're having condomless sex, and it's just in the context of that reassurance. And that's all we really do in our clinic. We would counsel them that it's probably not necessary, but that if that's something that they would like to do, then that's absolutely their choice. And this differs by province, right? Of course, our philosophy and our guidelines could differ by province. The other scenario is someone is with an HIV positive partner and they don't know if they are taking their medication, if they're seeking regular care. And so that might be a bit of a different scenario. This is a really nice study that was just published by Public Health Agency of Canada in 2021, looking at the changes in PrEP uptake over the last 4 years from 2016 to 2020. And I think certainly, you know, in contexts where there are virtual options, especially as we move into a virtual care world in the COVID-19 pandemic, that's been really helpful. But I would also say that because of the lack of comfort among generalist providers, virtual care might not be on the radar. People are still traveling great distances to seek out PrEP care. I'm going to switch just very briefly because Dr. Marie is going to spend the majority of her presentation speaking about women, but these are some high level points I think to think about when we're looking at HIV prevention in women and uptake. So truthfully, we don't have great Canadian data, but in the US, there's some really nice studies which look at the need, if you will, for PrEP use to person. So it's obviously been a lot lower among women, and the PrEP to need ratio was 5 times lower among women. Women have reported having low awareness of PrEP, anywhere from absolutely no awareness to maybe a third of people being aware. There are a lot of population-specific studies around adolescents, trans folks, and generally speaking, I would say that any of the qualitative research has showed that women are really frustrated that they're not being offered HIV prevention medication modalities as a part of their STBBI or contraceptive care. So there's 2 points. One is women are frustrated that it's not being offered and they didn't know about it. And the second is that women are specifically asking for it and are not able to access it. So we're going to speak a little bit about guidelines today, which are always tricky because guidelines are just guidelines, right? So there's 2 things that we need to think about when we look at access to HIV prevention medication. There's the guidelines, which could be American, Canadian, European, and then there's reimbursement criteria in our respective provinces. So when it's in the public formulary, who is the province willing to pay for PrEP? And I've chosen to just show today the CDC guideline that was updated in 2021 and sort of how you might approach looking at counseling, or maybe folks are even asking the provider for HIV prevention modalities. And you can definitely work your way through all of this, having a positive STI recently, having an HIV positive partner, having partners where HIV status is unknown. But I just want to highlight the light green boxes at the bottom, where it says, discuss PrEP and prescribe if requested. And so I think from a philosophical perspective, that's, at least in my opinion, where we need to be. If someone has self-identified risk and they're in the context of seeking HIV prevention, and it might not be with someone that they know very well, we should strongly consider it, if not universally prescribe it. In terms of women and PrEP, so just as a reminder, there's some absorption differences in terms of the anatomical aspect, but outside of the women's side, so when thinking about gay and bisexual men who have sex with men, we actually can do a sort of a specific thing around front loading daily PrEP. So that's 2 pills on the first day, and then 1 pill every day after that. And that is essentially the on-demand format moving into daily PrEP. In terms of some of the counseling, these are some things you could discuss. I think that Dr. Murray will go into greater detail, but when you're weighing out the differences between the 2 different PrEP combinations, thinking about things like, does this person already have a risk for renal disease or osteopenia or cirrhosis? And then the flip side of that is that TAF-FTC actually could lead to increases in weight gain and lipids. Importantly, although there's some ways to work with the manufacturers around both compassionate, I should say, as well as copay, this might not be covered in your province. Okay. I just wanted to bring this up because I think it's something we don't speak about enough. We rarely speak about PrEP use or PEP use, to be honest, amongst folks who inject drugs. There are some reasonable global studies. They're really difficult studies to do. And so therefore, the quality of evidence consistently says low. That doesn't mean we shouldn't do it, right? I think we might get in our own way around not offering things because it won't be perfect, knowing that people might not come back or we might never see them again. And I think that's okay. I think we really need to approach this from a harm reduction lens and make sure that PrEP is offered in overdose consumption, supervised injection, safer supply, and so on and so forth. So often we get referrals from point of care HIV testing programs. I think this is a really nice pathway to get to an HIV prevention clinic or medication. And I would say the one thing that comes up pretty often is the patient letting us know that they just had a point of care test. And so they might be at least somewhat frustrated that they have to repeat that HIV test so that it's a 4th generation test, which would be drawn through venipuncture. And so I usually approach this as like, yes, you would need to repeat the HIV test. And there is some guidance showing that maybe we shouldn't do that. But just to remind them that there's also some other blood work that we should do in order to safely start you on HIV prevention medication. Because HIV prevention medication is ideally long-term. We're going to have a long-term relationship with this person. I'm going to switch really briefly to PEP, post-exposure prophylaxis. This is from the Canadian guideline. there haven't been a lot of changes, but we are probably moving towards using an integrase inhibitor as that third drug. So it's like essentially PrEP plus an integrase inhibitor. This depends on what your province will cover. In Ontario, our publicly funded system does cover these medications in a bit of a roundabout way, if you will. And I know some provinces are moving to universal coverage, which is really, really important, although it's not always first line, for example, in Manitoba. It's extremely important to remember that most ER-based PEP prescriptions where folks are walking out the ER door with a few pills of PEP, it's typically not the full prescription. And there is a lot of evidence that shows that when people don't receive the full prescription, the rates of completion are much lower than if people receive all 28 days of their combination therapy. Now, HIV PEP needs to be accessed within 72 hours of the exposure. And so you can imagine in the course of someone's life, I've had folks who have gone to 3 different emerges, waited 12 hours in each emerge, left the third emerge right at the ending of that 72 hours, walked out with 3 days of medication and had absolutely no idea how they were going to access the rest of the medication because they can't access the public formulary in Ontario. I'm also going to introduce a concept, which you perhaps might not have heard of. So this is PEP in your pocket, or I call it PEP in your pocket. I guess technically it's called PEP in pocket. This was developed by Dr. Isaac Bogosh. He's at Toronto General Hospital, and you may be familiar with him because he's always on TV around the COVID-19 pandemic. He's done some really nice preliminary work, and now we're part of a larger cohort study to actually prescribe PEP in advance. So this is so people can avoid that emergency room visit. They don't want to be on daily PrEP. They don't want to be on on-demand PrEP. They might be using condoms all of the time, but they're very nervous about that condom breaking, or they might purposefully not use a condom, but only very few times a year. So PEP in pocket is really appropriate for people who have 0 to 4 exposures per year. We do the workup and give them a 28-day prescription in advance. Usually see them every 6 months. And these are some of the study results, but you can see this follow-up is extremely high. Just as a reminder that HIV prevention medication is only a small part of what we're doing in comprehensive HIV prevention care, because there's other things to consider, like vaccinations for hepatitis A, hepatitis B, and HPV, as well as screening for syphilis, hepatitis C, chlamydia, gonorrhea, rectal, oral, and vaginal or urethral. This is a newer document. So this is actually not from the Canadian guidelines. This is from a revised opinion piece around the types of screening we might want to do for PrEP care at baseline, 3 months and 12 months. And if we're thinking post-exposure prophylaxis or PEP in pocket, we're just going to add liver enzymes, so specifically ALT and AST. But a very important caveat, I think, and especially in terms of our practice, is that we should never delay PEP because we don't have baseline labs. I think for folks in the hospital system, this is extremely nerve-wracking, but it is actually really important that we don't delay PEP. Obviously, HIV medications do interact with a lot of other medications. And because of the nature of conversations around HIV prevention, many clients or patients don't speak about their sex life with their family docs, primary care providers, other folks that they might interact with in the healthcare system. And so it's really important that in counseling, patients are aware that they should tell anyone who's going to prescribe them anything that they're on this medication. But the flip side of that is when they do that in places like the emergency room, in mental health inpatient, the immediate thing that happens, I would say in my practice, 80% of the time is HIV testing. This person says, I'm on HIV prevention medication, and somehow that clinician heard this person has HIV because they're on this medication. And I think that's really frustrating for folks. We've created a bit of a tool to support people in deciding if they should be on daily prep, on-demand prep, or PEP in your pocket or PEP in pocket. Sort of takes them through what it would look like in terms of their appointments, who might be the best candidates for it, and sort of walking them through some self-reflection questions. This is available on the Katie website. And then I'll just share an overview of sort of what it looks like in our practice. So in Ontario, we have a fully virtual or online clinic, so we can work with folks from all over Ontario. And then we have 4 bricks and mortar clinics in different cities in Ontario. Our program is completely self-referral. We get referrals from people that are already in our program, from point of care testing programs, from community-based organizations, from, I always say, like, my number is written all over the city or province in terms of bathroom walls and things like that, where people are literally just calling. We're extremely, extremely low barrier. So we certainly connect with people through texting, email, however folks can get to us. In our models, we have some different models in Ontario. We have some pharmacist-led models, we have some registered nurse-led models, and then we have NP-led models. And so, either somebody at the community-based organization or the pharmacy, that's what the SRX is connecting with them and maybe doing some initial counseling. They're having somewhere in the nature of a 20-minute appointment, and whatever else they need in terms of testing, immunizations, and discussion around what's the best modality for them. The pharmacist would receive the prescription. They support us by doing interaction checks for the second time, and they navigate a lot of this reimbursement, but we're certainly very, very familiar with the reimbursement aspect. I just want to point out that you may need to enroll someone in a patient support program. And so for Descovy, that's that second medication that's better for folks with advanced renal disease, that they do pay the copay if people are privately covered in Canada. In Ontario specifically, pharmacists can extend prescriptions for 30 days. And so they often work with us to extend the HIV prevention prescriptions so that people don't have a gap in their care. I'm going to leave this one except to say that, we're looking towards a lot of different ways to engage with women and providers around HIV prevention in women, but also just to mention that, especially as it relates to women who engage in sex work or folks that might inject drugs, there are some possible other options coming our way, such as injectable HIV prevention medication. So I'm just going to go through a quick little case. This is a real story from one of our drop-ins when a person, if a person asked for contraception or emergency contraception, would they ever be denied? I think universally we would say no. That's why we made contraception actually over the counter, or sorry, emergency contraception over the counter, and why we've, as a society, created many, many options for women to access contraception in health units. And what we heard in our practice was that a woman was seeking OB-GYN care and specifically asked the OB-GYN for HIV prevention medication and self-identified as engaging in sex work. And the response from the OB-GYN was, this medication is for men who have sex with men. And there was no further discussion. So this is a new review, I should say, that I've been a part of, and I would encourage you to look at it, certainly in the context of the CDC guidance and maybe the Canadian guidance, but just sort of reframe how we're thinking about how we're offering or not offering HIV prevention medication to women. WHA also has some really nice resources around PEP and PEP in women. So just to check those out online if you like. And I will end there, and hopefully I'm okay for time. This is my niece. She's now 13. She would absolutely be embarrassed if she knew I was showing this picture, but that was her at a walk for HIV/AIDS when she was about 3 years old.
Thank you, Dr. Biondi. That was a fantastic overview. I am sorry, just going to try and figure out how to share my screen. All right, can everybody see those slides? Excellent. So I'm just really going to continue on from what Mia has said in her wonderful overview of PEP in Canada and PrEP in Canada. I'd just like to start by saying that I'm presenting today and respectfully acknowledge that I live, work, and play on the traditional unceded lands and waters of the Coast Salish peoples. So I just wanted to say that I'm in British Columbia, and these are my disclosures. And then just moving on to HIV prevention in women. For those of you who may not be familiar with this, this is the old data. So this data is now coming up to a decade old, a bunch of it, but this is kind of the data that is around PrEP and PEP for women, okay? And so the HPTN 52 study, this study was done on discordant couples, so one positive and one negative person in the relationship. And approximately half of them were from Africa. About half of the individuals in the study were men. And people at that time in those areas received antiretroviral therapy once their CD4 count dropped below 250. That was the guideline in the place at the time that the study was done. And so individuals were randomized to early therapy for their HIV if they were positive, or they were randomized to normal therapy, so getting HIV medications when their CD4 dropped below 250. And then the primary endpoint of this study was to see how many transmissions occurred to the negative partner when antiretroviral therapy was started early or not. And as you can see from this slide, there are 27 transmissions in those where ART initiation was delayed versus one transmission in the immediate. And the one transmission, actually, this person was infected before their partner was undetectable. And so what this really showed was that individuals taking antiretrovirals and undetectable don't transmit to their partners. And so this was kind of the beginning of U equals U. Okay, there were more than that in the number of transmissions, but when they looked back, they sequenced the viruses of those people who became infected and found that there were some that had not come from the partner who was taking the antiretrovirals. Okay, another study that was done, this one was also done in Africa, so it was done in South Africa, and this was looking at 1% tenofovir gel versus placebo for pre-exposure prophylaxis for women. It was used with intercourse. The device to administer the tenofovir gel is located on the right-hand side in the picture, and 889 women were enrolled in this study. 445 used the tenofovir gel and 444 used placebo. And the risk of seroconversion was reduced by about 39% overall. And you don't think that that's very much, but it was significant. And it was related to two things. So it was related to use of the tenofovir gel. So if you used it, it worked pretty well. And it was related to vaginal microbiome. So those with a healthy lactobacillus predominant vaginal microbiome tended to be protected, and those with more of a bacterial vaginosis phenotype were the ones that were running into trouble. And that was because there was a strain of bacteria in the second group that tended to eat the tenofovir for breakfast. FemPrep is another study. So this one took place in Africa as well for 1,951 high-risk women. These women took oral Truvada, and this study was actually closed early in 2011 as it did not show evidence of protection in an interim analysis. Going back, this was definitely related to tenofovir intake. So if they took the tenofovir and FTC tablet, then they were protected, but if they didn't take it, they weren't. And so uptake of the medication was low and there was no protection. All right, and then there's the Partners PrEP study, which looked at 4,758 serodiscordant couples. Here, the positive partner was not yet medically eligible for ART. So again, that CD4 of 250. And so what they did instead is the flip side of the previous study. Instead of treating the positive partner, they offered the negative partner either tenofovir daily, FDC tenofovir daily, or placebo daily, and then they follow them for 3 years. And this was done with heterosexual couples in Kenya and Uganda. And the primary endpoint was HIV infection in the negative partner, and a secondary endpoint was safety. And what they found was that tenofovir alone provided 62% protection against HIV infection versus placebo, whereas the tenofovir FTC or Truvada was a little better at 73% protection. Both of these significantly protective versus placebo. And again, when analysis was done later, how well this actually protected you was related to your adherence. And finally, the TDF2 trial was a randomized controlled trial of Truvada versus placebo done in Botswana with 1,219 HIV negative sexually active men and women, and approximately half in each arm. Almost half of the individuals were women. And what they found was that 9 on study drug became positive versus 24 on placebo. And this resulted in, again, approximately a 62.6% risk reduction. And so when you take all that together, this data was shown at CROI this year. This is a real world pooled analysis of 11 large studies with numerous years of follow-up. And it's in cisgender women who were taking FTC and tenofovir for PrEP. Okay, and you can see when all of these women were pooled and taken together, those women who were younger when they enrolled in the study, who were married, interestingly enough, and those with no children were the ones most likely to have HIV infection, to experience HIV infection. Okay. When they looked at whether the women took the antiretroviral prophylaxis, when they took the PrEP prophylaxis, to see if, what effect that had, they found that those with high adherence, so those that consistently took their tablets daily, had no infections. Those who took their tablets 4 to 6 times per week on average throughout the studies, there was only 1 infection. And those who initially started well, so this is the blue, they started taking their tablets very well, but it fell off over time, so taking 2 to 3 per week overall. Now starting to see a rise in number of infections here in this group, and those that never took it, again, high again. Okay, so less than 2 tablets per week. And on the left, on the objective, this is by looking at dried blood spots to see if they actually had levels of drug in their blood, versus the subjective, which is things such as the caps on pill bottles, self-report, and scales that assess how well people are taking their medications. So you can see when you actually look at levels in the blood, it tells a little bit different story to what people are reporting. But nonetheless, if women took their medications all of the time, they didn't become infected with HIV. Okay, and so what's going on there? Because we've heard about this ability to take on-demand PrEP. And so you would think that if they're taking tablets potentially more often around those times when they think they're at risk, that they might get away with taking 2 or 3 tablets a week. But this study published in The Lancet in 2011 shed a little bit of light on that. And so this, I can't see the bottom. This study looked at tenofovir concentrations 24 hours after oral administration in the blood, in cervical vaginal fluid, in vaginal fluid, and in the rectum. And what you unfortunately can't see in the bottom is that the rectal concentrations are approximately 2,000 nanograms per gram, as compared to vaginal tissue at 70 nanograms per gram, or cervical vaginal fluid at 70 nanograms per milliliter. The concentration of drug after 1 dose is approximately 100-fold higher in the rectal mucosa versus the vaginal or cervical vaginal tissues. Okay, and so protection in the rectum and protection in the vagina are not the same, and it takes longer to reach steady state. Okay, and in fact, PK modeling and studies have shown that the time to full protection from daily oral pre-exposure prophylaxis in the anus and rectum is approximately 7 days, versus in the vagina, it takes approximately 20 days or 3 weeks of daily medication before you reach levels that are consistently protective. So when it comes to those individuals who participate in anal sex, daily oral PrEP is a good option. On-demand PrEP is a good option. PEP in pocket is a good option. But when it comes to those who have vaginal sex, daily oral PrEP is good once you've had a bit of time to get the drug levels in your vaginal mucosa up to snuff. But on-demand PrEP falls off because those few days that you would take around a sexual encounter are not sufficient to protect you every time, and you're more likely to seroconvert. So those who have vaginal sex, this is not really something that should be ideally offered them. It should be daily PrEP, okay? Or PEP in pocket for those who have a low risk, okay? When it comes to injection drug use, again, daily oral or PEP in pocket. On-demand PrEP, I think we need more information about that. So what are all the guidelines? So if you in Manitoba or BC or Ontario, wherever you happen to be, if you go online, what do you find for the guidelines? So this is just a screenshot of the guidance that's available for British Columbia. So this is on the British Columbia Centre for Excellence in HIV website. This was initially released in August 2019 and then updated in 2020. Okay. And just something to say for BC, for British Columbia, all antiretrovirals, be they for HIV care, for post-exposure prophylaxis, or for pre-exposure prophylaxis, are approved through the BC Centre for Excellence in HIV. So there's one pot of money and one pot of drug there, and all applications have to go there. Individuals do not have to have health coverage in British Columbia in order to get that if they are living here. So you just have to apply and you can get the drug if you meet criteria. For Manitoba, the guideline was published in October 2021 and goes through eligibility criteria and clinical guidance for pre-exposure prophylaxis. Something to note is that daily PrEP was added to the Manitoba provincial formulary in the fall of 2021, so it should be available for people. On-demand PrEP is not, as far as I'm aware, covered. And then Ontario, in talking with Mia, they really were following the Canadian guidance, although this document published in 2017 and then updated in 2018 is outdated, and I'll show you why. So when I went through all the different guidance that's available for these three provinces, currently, the current guidance is pretty similar with a few little changes for each. Okay, so for Manitoba, if you're an MSM, syphilis, gonorrhea, chlamydia in the last 6 months, same for Ontario. BC, it's in the last year. Anyone having condomless sex with a positive partner who is felt to have a positive viral load, or in Manitoba who maybe last had a negative viral load but concurrent STI could be considered. Okay, but otherwise with a detectable viral load, and that is over 200 copies per ml in British Columbia. Sex with a partner who's felt to be high risk because they use injection drugs, where we don't know what their HIV status is, but they belong to a group that is at high risk, can be given PEP or PrEP. And then the HERE score. So in Manitoba, Ontario, a score of greater than 11 is used. There's a slightly different scale in British Columbia, and a score of greater than 10 is used. And then for all of them, repeat courses of post-exposure prophylaxis. So if you're requiring that repeatedly, you should be offered PrEP. Okay, so that's what it is for MSM. The data for other groups is a lot less well described. So for trans women, it really, all three guidelines refer back to MSM individuals. But for heterosexual men and women, it says, well, maybe consider in Manitoba if partner status is unknown, but from a high-risk group, so IV drug use, men who have sex with men, or someone coming from an endemic area. So that's good and not seen in the other two guidelines. Condomless sex with a partner who is positive but not stably on ART or undetectable. And similar with Manitoba and British Columbia, okay, with a partner, sex with a partner who's positive and not stably on antiretrovirals, okay? And then, maybe you could consider it in someone who is high risk but unknown, okay? For IV drug use, kind of similar, sharing with a positive person or someone who is felt to be at risk, and or if positive, not taking antiretrovirals. So this is kind of what it says. And if you look, we're kind of missing a few things here, okay? So first of all, we're really only looking at heterosexual men and women as individuals who may be exposed to some positive known partner, okay? And most other people are not included in this, and that includes those, who do sex work, those who have other risks that aren't exactly gathered here, okay? The other thing we're missing is trans men, right? And those individuals who are non-binary, and it doesn't really touch on that, okay? Looking at the Curie score. So this is the Curie score. This one is from Manitoba, but they're very similar for each of them. The only difference is that in Manitoba and Ontario, there's one additional question that's not asked in British Columbia. Okay, and that is whether you use amyl nitrate. What about for women and non-MSM individuals? So there's this one study in the literature that I was able to find that tried to come up with a score for women, okay? And this study was done among African women participating in a trial of the dapiravine vaginal ring. And, really looking for those individuals with at least a 2 or 3% annual risk of HIV infection as being those people that should be targeted for pre-exposure prophylaxis, okay? And you can see the score here. If you're a young age, if you're not married, if you don't have, your partner doesn't provide material or financial support, if you have other partners, alcohol use, curable sexually transmitted infections, or HSV. You can see that would actually include a lot of people in North America and might not be something that's quite what we would want to use here, because the incidence and prevalence of HIV in that area is much higher. When I looked around for what there might be in North America, there really isn't much of a score, but I guess that begs the question is whether we really need a score anymore, or whether we can move on to a more open way of looking at it. Other groups to consider, postmenopausal women. So in my clinic, I see lots of women who are postmenopausal becoming positive, and it's because once you go through menopause and that protective estrogen is not there, the vaginal epithelium becomes thinner, more likely to tear with sex, and therefore more likely increasing your risk of infection. Also, women who can't get pregnant anymore may not be thinking that they need to use condoms with new partners. Young women and girls have less mucus production. They also tend to have partners who are older and maybe more experienced, right? Concomitant STIs increase risk of HIV acquisition by bringing CD4 cells to the area. Okay, so, and women, adolescents, and trans persons may have less agency to request condoms and even to request PrEP. When we look at pregnant women as a group that's kind of not mentioned in the guidelines, but something to consider, women who are pregnant or postpartum are 3 to 4 times higher risk with each sexual encounter of HIV infection. And this is because of increased estrogen and progesterone, which causes increased CCR5 and CXCR4 expression, and change in innate immunity, an increase in inflammation, and an increase in target cells in the vagina. And so risk in pregnancy, particularly with a partner who may be positive and not taking their medications, or who may be having risk for HIV infection, is an important consideration. Something to note is that if a woman becomes HIV positive during her pregnancy, the risk of her transmitting to her child becomes really high. So if she has a viral load that goes up with acute infection, her risk of infecting that child goes much higher than it would at any other time. Okay, what about adolescents? So there's a neat new paper out from just last month on HIV pre-exposure prophylaxis for adolescents in Canada. Something to note is that youth 15 to 29 make up 25% of all new HIV infections in Canada. That's a lot. but MSM individuals are only a third to a half of these infections. Okay, so there's a large number of infections happening in youth that are not falling under the MSM guidelines. And the other things to consider is that many of these youth are non-binary. Many of these youth are young women. We have youth that are seen in the clinic here who are trafficked, who are in sex work, who have multiple, substance use exposures, for instance, and it can be quite complicated. And then the other thing is that these youth often won't identify these things if you ask them the questions. So they won't come out with it, what it is that puts them at risk. And so if you go with, just following these and you must check a box, you might miss them. And so from this paper, there was this nice diagram that suggests those individuals who are adolescents who should be offered PrEP. And these, those with a history of sexually transmitted infections, those with substance use, those with multiple partners and inconsistent condom use, those participating in transactional sex, those having partners of unknown HIV status, and then any adolescent who requests PrEP, because they're pretty in the know, and if they request it, there's probably something going on. So a conversation around why they're requesting it and offering that to them if they feel that they need it. And then the other difference with adolescents compared to many of the others is that there's evidence to say that they really need to be seen in follow-up more frequently, really approximately every month while they're on pre-exposure prophylaxis, because they have more difficulty in maintaining that adherence. For transgender and non-binary individuals, again, often face barriers to accessing PrEP, may have concerns about hormone use in ARVs, and so may not want to take them, but FTC and TDF do not interact with hormones, and so they should be safe. PrEP considerations should be taken into account, the type and site of exposures, and again, what you're offering should take those things into account. And so now really we're using the guidelines that are put out by the CDC in 2021 that Mia previously showed you, which is much more open. So those individuals not using condoms, those with a partner who may be positive and detectable, those with STIs, examples there, but also those individuals who are requesting it but may not be willing to tell you exactly what their risk is. So please consider that. Okay, and that's all I have for today. I think we have a few minutes left for questions. Thank you for attending and for inviting me.
Thank you so much to both of you. Folks, if anyone has any questions, please feel free to post those in the chat. I have a question that came in from one of our staff here at Nine Circles that I'll ask. Are there any specific considerations for HIV prevention in women who are pregnant or breastfeeding?
I can take that one. So we regularly use Truvada or FTC and tenofovir in pregnancy for women living with HIV, and there have thus been thousands and thousands of women who've been exposed to those drugs in pregnancy, and there's been no evidence of adverse effects to infants exposed to those drugs. So if a woman is identified at being at risk and wants PrEP, or you want to offer PrEP, do it. Okay, so the only potential thing that's been seen is potentially a decrease in bone density of the infant, but studies on those infants exposed to these drugs in pregnancy from positive women have shown that bone density rebounds after the child is born. Okay, as far as breastfeeding, again, a woman who acquires HIV while she is breastfeeding her infant and has a high viral load has a very high chance of transmitting that infection to her child. And so PrEP should absolutely be offered to a woman who is breastfeeding, who is at ongoing risk, because the effect on the child is negligible, and except that it may save them a lifetime of HIV infection.
Thank you so much. There's a great question here in the chat. If a provider was interested in prescribing PrEP, do you have any mentorship suggestions that you would assist a new prescriber, or any mentorship suggestions for that potential new prescriber?
You want to go ahead, Mia?
Yeah, I can. I mean, for me, obviously, the big difference is going to be that I'm practicing in a different province, and so there might be some small differences. I have shared my, I guess, sort of intake and follow-up stamps with hundreds of providers in Ontario, and I'm more than happy to be that sort of resource and, you know, have the informal consults. And, you know, sometimes people will send cases or questions by email, and I support that. I also do that in hepatitis B or C if that comes up in your practice as well. But Melanie, anything on your end? I know there's some formal things happening in British Columbia as well.
So I would say that, you know, particularly for women around pregnancy, breastfeeding, for adolescents, we are, you know, super happy to take any questions and to help. We regularly take questions from providers all over British Columbia and sometimes elsewhere around management of HIV and pregnancy and PrEP and pregnancy and in youth. And I think just reaching out to myself or one of the other providers at Oaktree would be absolutely reasonable and welcomed.
Thank you so much. Another great question here in the chat. During your presentation, you mentioned some side effects of the drugs. Is there a suggested timeline for review of PrEP use to prevent long-term negative effects, particularly for young folks or adolescents?
I don't know, Melanie, I'll do a quick response and you can add. So, I mean, as per the guidelines, we would try to see people when they've been on PrEP for about 2 weeks. The intention there being to review side effects, see how it's going, and get that next set of blood work sort of organized so that people have a second HIV negative test before prescribing 3 months at a time. For doing this for 6 years, I can tell you that people think that's a lot of care in a short amount of time. So I think just explaining why it's so important. Anything to add, Melanie?
My only thing to add is if it's PrEP for adolescents, my pediatrician colleagues who regularly prescribe for adolescents would say that you should have them back every month, at least for the first while. So that differs from adults, where it would be every 3 months once they're established. And that is because their brains, you know, their frontal lobes are not fully developed. And kind of the constant circling around and monitoring, and it can sometimes really improve their uptake. And then for individuals who may be breastfeeding or pregnant, again, we would tend to see them fairly regularly and monitor and make sure that they're doing okay on those medications in those circumstances, sometimes with more frequent blood work.
Thank you so much. Another question coming in here. Is there any specific PrEP or PEP certification programs that you know of?
So, I mean, in some provinces, you must do a educational program, Saskatchewan, I think Alberta. We've developed some provider-facing modules, which for me doesn't impact me at all because I'm not a physician, but I think they are accredited. And I know there's some in British Columbia, so I'll let you answer.
There are the guidelines. I'm not aware of anything that's required for a certification program in British Columbia. I know all of our providers do it, but don't necessarily have to take a certification program. But I'm not sure for family physicians if that differs.
And for all the folks on this call, we did also send out some Manitoba-specific resources for you to review that might answer some Manitoba-specific questions as well. One more question before we end this call here. What role do or can community-based organizations and folks with living experience play in promoting HIV prevention among women?
I think community involvement is fantastic and needed all along when it comes to research, when it comes to clinical care, when it comes to getting the word out. Because, you know, primary care providers, infectious disease doctors, nurse practitioners, right? you can't know everything about everything. And so like the case that you mentioned, Mia, where, you know, a woman asked and was told, no, this is just for MSM, right? It's good for individuals to have connections and those who are in the community to get the word out so that that person can say, actually, I heard this, and to be able to question that person and get them to go back and learn and potentially offer service. So I think community partners are so invaluable for that.
Yeah, and I think as these programs grow, like when we first started, I actually wasn't doing the intake at all. We had only community-based organizations doing the intake, and that sort of morphed into them doing a lot of the education first before they see me. And so it's pretty seamless. I would also say that the self-referral aspect, which is often friend referral, is really important in terms of that word of mouth and who you can access.
Thank you so much to both of you, and thank you for your time and your expertise, sharing your knowledge today. For folks on the call today, we will be sending out an email to you with a brief evaluation survey, so you can let us know how you found this webinar and to allow us to continue to improve our webinars. And we'll also be in touch with you because we're hoping to continue this conversation. We know that HIV prevention medication is a very important topic. So if you feel your questions weren't answered today, or you think of more questions, we'll be following up with you about future opportunities to engage on this topic. And thank you again so much to Dr. Melanie Murray and to Dr. Mia Biondi. And thank you everyone for your time today and attending this session.
Thank you.